There we go. Okay, so now we're recording. So damage done from the injury. What the body's going to do is try to contain the effects of the injury. Okay, so what happens? What's called during the primary stage. That's when the injury happens. That's the actual cut. That's the actual gash that you get, the scrape, the surgical incision that you get. Okay, that damage is irreversible. But then after that, the body goes into, I mean, like seconds later, it goes into this drive to contain the effects of the injury, limit the amount of secondary injury. And when I say secondary injury, I mean things like infection of the wound or further damage to the wound, but mostly infection. The body's going to try to limit that amount of infection, and that's called secondary injury. Okay, so after the injury, dead and damaged cells are going to release a lot of their contents, their cellular contents, into the circulatory system. Okay, a lot of times we call those cytokines or inflammatory mediators. All it is the cells that are damaged or have been killed by the injury are going to release their inner substances. Well, some of those things are kind of like little flags that go to other parts of the body and tell the body, hey, some kind of damage has happened. Some cells have died. Some cells have been damaged. I'm an inflammatory messenger, and I'm telling you something's happened. Okay, so when that happens, the body goes into a kind of like an emergency mode. It's going to build up fluids, what we would think of as edema, around the area. Okay, as it's doing that, it's clogging up the vasculature with its own edema. Okay, so you might think, well, that doesn't sound good. Well, it's not good. So then, since we're getting more and more swelling of the area and edema, we're clogging up the vasculature. So further cell damage is now going to happen from lack of oxygen. So a little bit of swelling is okay because that's our body's way of immobilizing a part or letting us know, hey, something's wrong. Don't move this joint. But a lot of swelling obviously is going to be bad because that's going to cause further cells to die. Okay, and that's just an injury process that can just become a little bit of a cycle for a little while and eventually result in pain and ischemia. And ischemia means lack of blood flow. So you'll have some further cells. So after you have the initial injury, you're going to have some secondary cell injuries from the swelling that's going to cause more cells to die. Okay, this is going to be a little bit of a cycle until things calm down. You may have muscle spasms at the same time. Okay, and that little cycle is going to go on until enough of the dead and damaged cells have been taken away, and then the next stage will start. Okay, so everything that I just described to you is in the inflammation phase. The first, and this says day 0 to 6. And you can see that on these stages I'm about to tell you that the days overlap a little bit. That's always going to happen because it depends on the size of the wound, the depth of the wound, whether the wound was infected or not, whether it was a surgical wound versus just an injury wounds, things like that. Jagged edges versus smooth edges, depth of the wound, things like that. Okay, well, all those things as far as cells releasing their cytokines and inflammatory mediators, those things, the swelling happening, that's all happening during the inflammation phase, day 0 through 6, or day 0 through about 6. This is preparing the wound for healing, okay? Well, then the next stage, which you'll see next, we're going to move into, it's called the proliferation phase. This is where the body starts rebuilding damaged tissue and strengthens the wound. So think of strengthening the wound as the wound is healing, the body is rebuilding damaged tissues and structures, okay? So this can, for a small wound, this can start happening as early as day 3 or as late as day 20 if it's a big wound. Okay, the final stage is called the maturation phase. This is when scar tissue has formed on the inside and the outside. The wound is healed, and now the scar is being modified into its mature form. And let me tell you this, I think I might have said this in an introductory lesson. Just because a scar has been formed and it's closed doesn't mean healing is over. We still have some work to do on that scar, because if we don't work on the scar, it's going to cause some problems. And if any of you have some scars like over your knees or elbows that are really, really tight and limit your range of motion, keep that in mind. I will explain that a little bit further later on, but if you have a scar that over a joint or something that limits your like bending or straightening or limits how far you can move, keep that in mind. I might need you to as an example sometime soon. Okay, this is a very, very, very long flow sheet that you can go through on your own, but it's very, very good to let you know everything that's going on during the different stages. So I am going to go through it real quick right now, because there are a few things I didn't mention. Now, this is probably too small for you to see on your screen, so I apologize, but you can see it on your own PowerPoint. So in the inflammation phase, we're going to have vasoconstriction first, which is going to be the vessels are going to constrict so not as much blood flow can come into the area, okay, because we don't want a lot of ischemia. As soon after the insult is over, we get vasodilation, the opposite, where blood flow is allowed to come into the area again. Then we get clots formed to stop the bleeding, and then phagocytosis is the act of white blood cells actually going in and killing the foreign bodies. So if there's bacteria in there, if there's foreign bodies like dirt or little shards of something, the white blood cells will go get those. Okay, next stage, proliferation. This is when we have fibroplasia. That means increase in fibers are being produced, collagen is being produced. Epithelialization means new cells are producing on the wall, on the different layers. Wound contracture means the wound pieces are coming together, and neovascularization means new blood vessels are forming. So that's all good stuff. That means things are healing. You want that to happen during the proliferation phase. During the maturation phase, we have more collagen synthesis. Collagen fibers are being oriented in lines of the actual tissue. So a lot of times what's going to happen when the body, with any wounds, and we'll talk about this later in later chapters, whenever the body starts laying down scar tissue after a wound, it's going to lay down collagen fibers. Well, it's going to lay them down in this way, this way, this way, this way. It's going to lay them down in just every which way possible. It's not going to go along with the grain of the tissue, okay? It will never do that. It would be great if it did. But collagen just lays down just like random pieces of tape or glue that you would just stick on, or Band-Aids. Well, it's our job to go through there and help the scar mature so that all the collagen fibers are aligned so that the scar is nice and soft. We will get there another day. Okay, so here again, we'll break down the phase of inflammation. So acute inflammation can be 0 to 14 days. Subacute, which is coming out of it, not quite as bad, starting to heal, starting to get better, is 2 to 4 weeks, and then chronic pain is going to be usually anything after a month. Okay. Chronic inflammation, I'm sorry. We'll go through pain in a minute. Okay, this just gives you a little chart on how much time it takes for the different stages. You can see that the maturation phase is definitely the longest phase, even though we might think we're healed way before it's done. There is a lot going on the inside that we can't see. Okay, this is a very good little chart for you that I want you to look at. It's probably much too small for you to see on your share screen right now. It's barely big enough for me to read, but if you look at it on your own computer, you can probably see it. And this just goes through the different cytokines and inflammatory mediators that the cell releases when it's damaged, and exactly what those do. Just be generally familiar with this. You don't have to remember certain chemical names and certain cell names, but I do want you to know generally what is going on during this little chart. Once you blow it up and read it, it'll make sense. Okay, let's talk about factors affecting healing. So, obviously, type, size, and location of the injury. So, if you have an injury, if you have some tissue that's well vascularized, that means it gets good blood flow, it's probably going to heal pretty quickly, as opposed to if you get injured at an area with poor vascularization. So if you tear your meniscus in your knee, which is the pad of the shock absorbing pad of cartilage between our femur and our tibia, that's going to take a long time to heal because cartilage has very poor vascularization. Cartilage gets very, very, very little blood flow in our body. And that's just how it is throughout our whole life, mostly from adulthood. Cartilage gets very, very poor blood flow. So if it's damaged, it's going to heal very, very slowly on its own. It may not heal completely on its own. Smaller wounds are going to heal faster than larger wounds, and that just makes sense. Surgical wounds, usually because they're nice and smooth and a straight cut, usually heal a lot faster than blunt trauma wounds. And just think of a trauma wound could be a sharp object going into your body, tearing your skin, something entering you, or getting hit with something and tearing you open, or a bone breaking and sticking out of your skin, which happens sometimes. Those are blunt trauma wounds. Those are jagged edges all over the place. Surgical wounds are nice and straight edges. Soft tissues over bony areas. So think about your tissues over bony areas, like over your olecranon, over your patella, over your trochanters, like over your acromion. Those tissues are right over bony areas, and they don't have a lot of there's not a lot of tissue there to begin with. It's just because you can feel the bone, so those tissues don't get a lot of blood flow either, so they're going to heal a little bit slower than tissues that are not over bony areas, like say the back of your thigh, where it's real nice and soft and there's muscle there and there's fat pad there. That's going to heal faster than over a bony area, because another thing that the bone is going to do is prevent as much oxygen from coming in through the blood, and prevent a lot of blood from coming in. Any wound that's infected is going to take a lot longer to heal, and honestly, no healing is going to take any effect until the infection is gone. So if a wound is infected, that's the first thing that the clinicians are trying to get taken care of, is the infection. And the vascular supply. The more vascular supply an area has, the more blood flow it has, obviously, the faster it will heal. Other factors, external forces like movement. Moving, the early movement in the injury process may delay healing. You could open up the wound again, or even if you don't open up the outside of in part of the wound, you could be damaging things on the inside of the wound. So that's why a lot of times after someone is hurt, they're immobilized. They may have their arm in a shoulder sling for a week or so. They may or after they have a lot of times after people have rotator cuff surgery, they're in these big shoulder immobilizers. They have pads and pillows and things, and they have to stay in a certain position for a certain amount of days or weeks. Sometimes, obviously, if people have like a cervical spine injury, they have to wear like a cervical collar to keep their head and their spine immobilized, so they don't cause it move anymore, which would cause more damage. So sometimes immobilization is to prevent further damage in problems. Now, eventually, you do want to start moving the damaged area, or it will get stiff and it will be healing that way. Other factors affecting healing: age. The younger you are, the faster you heal. Disease, diabetes is always going to make you heal slower, as will suppress immune system, and cardiovascular disease. Medications. If you're on corticosteroids, steroid medications for steroid like injections to joints, or steroids like a lot of people that have chronic lung problems like COPD will take corticosteroids to help open up their breathing. If a person is on corticosteroids, then they're going to heal a lot slower than normally, okay? That goes along with NSAIDs. Don't worry what it stands for yet, but it stands for non-steroidal anti-inflammatory drugs. Those are things like, those are common pain meds like ibuprofen, Aleve, aspirin. Those are NSAIDs, okay? Those are non-steroidal anti-inflammatory drugs. So they're different than corticosteroids. But if you're taking a lot of NSAIDs, like you're taking a lot of ibuprofen after your surgery or after your injury for pain, that's actually going to slow down your healing a little bit. It'll slow down the protein synthesis. So it is okay to take those medicines because, hey, I mean, if you're in pain, you want to get rid of the pain if it's a lot, but you've got to balance it because you don't want to take too much and be taking it around the clock, or you'll be drastically slowing down the healing process. And nutrition is very important for the healing process. Obviously, a well-balanced diet is going to be needed. But if you have a large wound, you can supplement your diet with a lot of vitamin C, because vitamin C is needed for protein synthesis in the body. So while you're healing, if you take a lot of extra vitamin C, there is some evidence that it can speed up the protein synthesis and speed up your healing just a little bit. Okay. So that's all on wounds and healing. Anybody have any questions on that? I did go through that pretty quick. So any questions on that? Okay. All right. So let me check the chat. All right. Nothing. Okay. Well, if we're good, we will go into the pain lecture. And the pain lecture is a little bit more in depth. So let me find it. Can't find it. Here we go. So oops. Don't know what I'm doing here. Do y'all see the PowerPoint now that I switched to that says pain?
Yes.
Yes. Okay. Very good. Okay. So I had to get a shot of caffeine. Now, I will tell you, some of the pain lecture is going to make sense. Some of it, I just need you to open up your mind, be a little open-minded, use your imagination, and make sure you go back through your book later. Your textbook that you've got, this is actually we're using this textbook again. We used to use this textbook a while back when I first started, and then we switched modality textbooks for this class, and I didn't like it as much because they didn't give good explanations. But now we've switched back to the old one again, and this is the new edition that y'all have by Dr. Cameron, Physical Agents in Rehab, in the orange book. It's a really good book, and it really does explain pain really well. So if I don't explain it very well, try to read Dr. Cameron's explanation. It's a little bit in depth, but it's all good. It's good. Okay, so what is pain? We've all felt pain before, but exactly what is it? Okay. Well, it's an experience, obviously, in your brain that's based on an interaction of physical and psychological processes. Okay, so pain is a warning to our brain to protect us from bodily damage. So pain is a protecting signal to let us know, hey, do something, or you're about to get hurt, you're about to experience tissue damage, or something like that. Okay. No, I think we all knew that. Now, here's a new term you need to know: nocioception. Nocioception means the activation of receptors of noxious stimuli. Noxious, if you don't know what that means like bad, painful, aggravating, annoying, nagging. So something that's noxious is not fun. Something that's noxious is usually bad or uncomfortable. So when we say a noxious stimuli, that usually means a painful stimuli. And as you might be guessing, the cells that are responsible for feeling out noxious stimuli are called nocioceptors or nocioreceptors. Okay, pain is going to be one of the most common symptoms reported by our patients. So no matter what their diagnosis is, no matter what we're treating them for, no matter what kind of area of specialty we go into, pain is going to be one of the most common things people report. So obviously we can be treating people for who knows what, but they're going to also have pain somewhere along there too, probably. So we're going to have to be treating their underlying pain also. So keep those things in mind. Okay, well, let's talk about types of pain. Okay, we'll talk about acute and chronic pain. Acute pain usually consists of unpleasant sensory, perceptual, and emotional experiences. So your emotions are involved. Okay, acute pain is generally well localized and defined. And when we say localized, I mean if you can usually pin it down to one specific plot space. You're not going to feel it everywhere all over your body. It's not going to be like my whole leg is hurting, my whole arm is hurting. Localized pain means it's pinpointed. You know exactly where it is, and you can touch it and pinpoint it with a finger. It's well defined. That's how acute pain always starts out. Okay, the intensity and location are almost always going to be related to the degree of tissue damage, which kind of makes common sense. The more damage you have, the more pain you'll have. The pain sensations in the skin, the pain nocioceptors in the skin are very localized. So if you have a wound that's more just in your skin layers, you'll be able to feel it. But if the wound goes down in the muscle, it'll feel a little bit more widespread and achy because the nocioceptors in the muscles are more diffuse. That means they don't really let you know. They're not as specific as to where the pain is. So when a nocioceptor in a muscle which is deep down in our tissue, feels pain, is activated. It just gives the feeling of a deep ache, maybe a cramp, or like a muscle soreness, something that you know is there, but you can't really do much about in the moment. Okay. Now, acute pain usually lasts only as long as the noxious stimulation is present. So as long as that sharp object is sticking into the skin, noxious stimulation is present. As long as that bone is sticking through the skin, noxious stimulation is present. As long as that wound is brand new and been cut open and they haven't closed it yet, and the person's not been seen yet in the ER, that noxious stimulation is going to be present. Now, acute pain may be very uncomfortable, but it's very important and functional by the body because it serves as a function by protecting our activity. It tells us don't move this part of the body. And in this and when there's acute pain in this stage of injury, you really don't want to move that body part because you could cause further injury. Okay, now let's move on to chronic pain. Chronic pain always starts off as acute pain, but now it's pain that does not resolve in the usual time it takes for disorders to heal. So this pain has continued beyond the duration of the noxious stimuli. So think of, let me get through these bullet points and then we'll talk about it. So most authors define this type of pain as lasting longer than 3 to 6 months after an injury. So think about, you have an injury to your shoulder. So you have a rotator cuff tear and you go and get your surgery, or maybe it's not big enough for a tear. So you go and get your rehab and you get stronger and everything. Excuse me. Well, let's say that you let's say you do 90% of your home exercise program. Let's say you don't do quite all of your stretches and you don't do quite all of your strengthening things. Or maybe you do everything that you're supposed to be doing, but you just don't do it to the intensity you're supposed to be doing it or long enough. Then you can develop chronic pain, which is pain that is a continuation of your original noxious reason for pain, but this is pain that's continuing beyond the usual amount of time it took for disorders to heal. Okay, so chronic pain is usually lasting for 3 to 6 months or longer, and it's generally associated with physical, psychological, and social dysfunction. So think about a person you know that may have had low back pain, like any of our parents, or all of, like, my parents are getting a little bit older right now. I still have my grandmothers; they're up and active. You know, they've developed chronic pains. Like, I know that my dad has chronic low back pain, and so does my mom. And it's not really related to a specific injury they had, it's just related to aging. But theirs is something that comes back every once in a while. So that's a chronic pain due to aging. It's not a chronic pain due to an injury, okay? Now, those types of pain can definitely be taken care of with stretching and strengthening, just like we can do with any other types of patient, but they have to remain doing it the rest of their life. Okay, let's talk about more about chronic pain, because it can cause some chronic pain, if you don't take care of it, can cause some problems. So chronic pain can be the result in changes in the sympathetic nervous system if it goes on long enough, and in the spinal cord neurons. Okay, if that changes, if you have some sympathetic nervous system changes, you're going to have changes in your pain perception, and it's going to be called central hypersensitization. Remember that term, central hypersensitization. All that means is that you are around the area where you had the injury or the surgery, you are now hypersensitive to any physical touch or movement, okay? That means somebody can barely touch you, or you can even just put your shirt on and the cloth going over your skin will be painful to you, okay? Small additional stimulation is very, very painful. That's called central hypersensitization. Or maybe it's not just light touch that makes you hypersensitive, but maybe it's moving through your range of motion is extremely painful and more painful than what it's supposed to be. Maybe more painful than after the injury itself. That's called chronic pain and hypersensitization. That's never a good thing. Once the sympathetic nervous system changes like that, it is possible to help it go back to normal and change back, but it's very difficult. Back to chronic pain a little bit. Chronic pain, as you can probably imagine, has a lot to do with disturbed sleep. People don't sleep very well with chronic pain, and that's always going to be associated with depression. If you don't sleep well, you're not going to be rested well, and that's going to put you at very high risk for developing depression. No matter how strong of a person you think you are emotionally, you're going to always be at risk of depression with chronic pain. And people with prolonged pain are at risk for severe disabling. Let me start over. People that have this very severe acute pain are going to be at higher risk for developing chronic pain, because if they have very severe acute pain in the beginning, it's obviously going to take longer for that pain to go away. So they may start developing some central hypersensitization before their wound is even completely healed. And that would be in severe cases, but not all is lost. It's just going to take them a lot better to get back to normal. Any questions on hypersensitization before I move on? Okay. So, different types of pain. Pain can be felt at a location distant from its source, which is called referred pain. So, referred pain is often goes from one joint to another or one body part to another. So, if a person develops hip problems and then they have hip pain, it's often going to refer to the knee and then to the back. So then you'll have the hip, knee, and back pain. Well, now we have to treat all three, but usually in therapy, if we treat the hip pain, if we recognize that's where everything is coming from, the knee and the back pain will help themselves. You can have referred pain from a peripheral nerve to a distal area of its innervation. So like if you had a nerve injury somewhere in your arm or leg, and you had nerve cut or frayed or something from just an amputation or a really deep cut or gouge or laceration or something, you can have pain down the rest of that extremity for the rest of your life or for a while, because it's coming from a nerve that's damaged. Even though you're not feeling any damage in your hand or leg, the nerve up more distal in your arm is damaged, and it thinks it feels pain. It's just a damaged nerve. Think of it as a damaged computer chip. And from an internal organ to another area of tissue. So like I think I mentioned this before, a heart attack can cause pain in the upper chest, in the shoulder, particularly the scapula, and the jaw and the arm. And the gallbladder refers pain to the right shoulder and the right scapula as well. So even though those organs and those places are completely different places and areas of the body, they still share pain. Kind of weird. Okay, let's talk about all those a little bit more. So we'll talk about referred pain. So referred pain can happen from a few different ways. From a nerve to its area of innervation, which is like a peripheral nerve, which we talked about. Like if a nerve gets cut up distally on your arm, you can feel the pain down further, from one area to another area derived from the same dermatome. So I don't know, I think y'all are gonna learn dermatomes this semester, but dermatomes are basically a mapped area of skin that is innervated and represented by one nerve, okay? So if let's say that you had an injury and it affected your C5 dermatome. I'm sorry, your C5 dermatome. Which way? This way. Right here on your elbow, lateral elbow. And then if you have some damage that happens there, well, it may cause more damage down the length of your arm too. Also, from one area, we can have referred pain from one area to another derived from the same embryonic segment. So think about when we're embryos and we're just a few cells big, we're just a ball of cells. All we are is a ball of stem cells. And then those stem cells develop into what we are, a whole body, a whole mature body with different structures, different tissues, different systems. Well, all those systems come from the same few embryonic segments or groups of cells. So that's why they think that if you're having a gallbladder attack or pain, you feel it in your scapula or in your arm, because those areas may be related embryonically. Now, there's no way we can map that out right now, but that's just a theory. Just something mapped out. You have a picture you can look at. Okay, let's talk about neuropathic. Any questions on referred pain before we move on to neuropathic pain? Okay. Well, neuropathic pain, look at the word neuro. It's nerve pain. Neuropathic pain is nerve pain. So this is going to be as a direct consequence of a lesion affecting a nerve. Okay. So very common in people with diabetes, very common in people with spinal cord injuries, very common. GBS stands for Guillain-Barré syndrome. Neuropathic pain is very common with people after amputations. They can still feel pain in their remaining limb, even though that remaining limb isn't there anymore. Nerve pain is its very own type of pain. It's like a burning pain. You feel burning, kind of like you're getting hit with sharp needles, kind of like if your foot or your leg falls asleep and you feel like you're getting bit with ants or sharp needles dancing all over the place. Not really, it's kind of painful, but more annoying, and it takes a long time to go away. That's neuropathic pain. Burning. Paresthesias is maybe you feel tingling and numbness. Itching, where they feel a lot of itching at that limb. Or anesthesia, where all of a sudden it may go completely numb, or where they may have some weakness in that area. Those are definite. Those are all evidence of neuropathic pain. Okay, so neuropathic pain is going to be more sensation related pain. Like there's going to be maybe a little numbness or tingling, that burning or itching or ant-like biting that you feel when your foot goes to sleep, or anesthesia where you can't feel it much at all. Okay. Nerve pain is usually pretty easy to to describe. If you were asking people to describe their pain, if they say it's burning, itchy, kind of pins and needles, that's neuropathic pain. If it's achy, kind of dull, then we know it's maybe muscular pain, but we'll come up with that later. Okay, let's talk about these two theories real quick. Easier to understand than what it looks like. The specificity theory just says the sensation of pain depends on the specific type of stimulation and nerve ending that was hit. So that basically means the specificity theory means the specific type of pain you're going to feel is going to be based on what type of nerve ending, what type of nocioceptor is activated. So is it a temperature nocioceptor? Is it a pressure nocioceptor? Things like that. That is the specificity theory. The pattern theory just says the sensation of pain results from intensity and frequency of stimulation to the nocioceptors. And the pattern theory says that the nocioceptors all respond to about all the different nocioceptors respond to kind of the same things, but that it depends on how much stimulation and the type of stimulation they get as to what type of pain you feel. Okay, so let's define those again. The specificity theory says that there's certain nerve endings or nocioceptors in our skin that are made to feel specific things. So there's specific nocioceptors for pressure, specific nocioceptors for heat, specific nocioceptors for cold, specific for sharp, specific for dull. And then the pattern theory just says that we feel things that the nocioceptors are all kind of the feeling of the same thing, but they're giving us the sensation based on the intensity of the stimulation and also what is being the characteristics of what's actually happening to us. So is it heat? Is it cold? Is it pressure? What wins more over the others? There's not one of these theories that's been proven more right than the other one. You just need to be familiar with both of them. This is just kind of an example of each. Kind of hard to understand this. Okay. Current theories integrate components of both the specificity and the pattern theories. Okay. So currently, most scientists and people out there believe that the specific nerve endings called nocioceptors, which we've already defined, respond to all painful stimuli, kind of like the pattern theory says. And then there are specific nerve types which transmit different types of tissue. Different types of sensation. So we'll start going through those next. Pain from cutaneous. This is skin tissue, usually a sharp, prickling, tingling, well localized. So anything on the surface that you feel is going to be really well localized and very acute. As long as when it's taken away, the feeling will go away. Musculoskeletal pain, which is usually a little bit down deeper, is going to feel more dull, heavy, achy, and harder to localize. Like, well, if it's in your leg, you'll know where the pain's in your leg, but you might not be able to point specifically to what part of your leg it's in. It'll be more achy. It'll just be more kind of constantly there, dull, and real heavy feeling. That's musculoskeletal pain. Visceral pain is very similar, and that would be our organ pain, very similar to musculoskeletal pain. It tends to feel really, really deep. And it tends to feel dull, long-acting, and aching. Okay. Now let's talking about specific pain receptors. So we know nocioceptors are free peripheral nerve endings that are in the dermis and the epidermis and in the muscles too. They can look like a string of beads, like a long string with different receptors all up and down them. And they're present in almost all types of tissue throughout our body. And they can be activated by thermal energy, mechanical, which means pressure. Think if you took your finger and you poke yourself in the side of the shoulder, or you poke yourself in the arm, that's mechanical pressure. Or if somebody bumps up against you in the grocery store or in the hallway, that's mechanical pressure. You feel them bump up against you and the pressure. Or chemical stimuli from within the body or outside. So if something gets spilled on you and it burns, you need to wash it away. Something like that. Well, all nocioceptors, wherever they are, this is something important too. When they're activated, they release a substance. And for all intents and purposes, it's got a long name. We're just going to call it substance P. Remember, substance P for pain. When substance P is released, that is letting other cells in the surrounding area of the body know, hey, something's going on. Get ready, because we may be having an injury here, or something's going on outside the body. Just get ready. And so that can kind of get our muscles ready to accept a load. Maybe we're just getting ready to pick something up, or maybe we're getting ready to catch something, or maybe we're anticipating something. Maybe we're anticipating a shot. We're in line to get our COVID vaccination, and we're anticipating a shot. So we're just sitting there, and we even haven't felt it yet. But as soon as that needle goes in, substance P is released, and then we feel all the pain throughout our shoulder. Okay. Now, these next few slides are very, very, very important. They're going to go through specific types of nocioceptor fibers, okay? So you have to know these. So don't just try to memorize these PowerPoint bullets. Try to make yourself a little chart or something to try to you can look at the similarities, the differences, those things. The first type of fibers we're going to be talking about are called C fibers. Okay. Now, all these nerve fibers that we're going to be talking about, let me back up. They're all afferent fibers, which means they take their information from the periphery of the body up to the brain. Okay. So they're taking information from the body up to the brain. Or they're ascending fibers, also sometimes known. They ascend the spinal cord to go up the brain. Okay, C fibers. These are nocioceptors. They make up about 80% of our pain transmitting fibers. So that's easy to remember. C fibers make up 80% of our nocioceptors. That's almost all of them. They're very, very small nerves, but they're unmyelinated. They don't have any myelin around them, or that protective insulating sheath that like most wires have. So because they're unmyelinated, they're going to conduct their action potential very slowly. And you can look here, 1 to 4 meters per second. Now that's pretty fast to transmit an action potential, but compared to other nerves in the body, that's actually pretty slow, believe it or not. So they're small and unmyelinated. C fibers respond to noxious levels of mechanical stimulation, thermal, and chemical stimulation on the body. So if there was pressure on the body, like you were getting poked with something, or somebody was leaning up against you, you would feel it with a C fiber. If there was something cold or hot or warm or cool up against you, you would feel it with a C fiber. And if there was some chemical on you, like say you put a topical, like a ointment on you for pain, and it's got menthol in it, and makes you feel cold, that's actually, your skin is actually not getting cold. That's just the menthol That's just the menthol molecule reacting with a nocioceptor to make you feel cold, to think you're feeling cold. And then it'll eventually feel like it's going hot. That's how those topical things work. You're actually not changing the temperature, you're just activating the specific nocioceptors. C fiber pain is dull, throbbing, aching, or sometimes burning, but usually not burning. It's usually dull, throbbing, and aching. Can be a slow onset after the initial painful stimulus. So after the painful stimulus is there, it can get worse and worse and worse, long lasting. It's emotionally difficult. This will be an example. This will be a type of pain that makes you sit there and cry because it's so painful while you're in pain. Makes you panic, makes you freak out if you can't help yourself, if you need help, things like that. It's diffusely located. That means you may know that you just broke your leg, or you know that you just got burnt, but you feel it all over the place. So it's hard to localize. You may even be able to see the injury yourself with your eyes, but you can feel it all over the place. Causes bodily sweating, increased heart rate, blood pressure, and nausea. And it's also, you do need to know this, that pain associated with C fiber activation can be reduced by opioids. So this is most of the pain that we feel. A lot of times this is going to be most of the pain, post-surgical pain that people feel. They're going to feel the dull throbbing and the aching on the inside. Can be emotionally difficult, can be a little depressing, can make you kind of sad, kind of down, but this can be reduced with opioids. C fibers, though. Not all fibers work with opioids, so that's why I want you to remember that with C fibers. Oops. There's C fibers. Let's go to A fibers. A delta fibers, okay? A delta fibers are also ascending fibers that go up to the brain. They're also small nerves, but they're myelinated. So they're different than C fibers. These, look how fast these transmit an action potential. Because they're myelinated, they can transmit up to 30 meters per second. That's super fast. That's faster than any of us can even comprehend. Well, they only make up about the remaining 20% of the afferent pain nocioceptors. Okay, these are sensitive to high intensity mechanical and thermal stimulation, like really, really hot, really, really cold that touches you really quickly, getting stabbed, getting something sharp pinned in you like a knife or a splinter, getting pricked with something. If you pick up a flower and you get a thorn and it's that quick sharp feeling, that's an A delta fiber helping you feel that. It's a sharp, stabbing, prickling feeling. It's a quick onset of pain, lasts for a long onset of time. I'm sorry, I read that wrong. Lasts for a short amount of time. Usually lasts only about as long as the thing causing the nocioception is there. So if you take the splinter out, the pain will be there for a minute, but it'll go away. If you take the intense hot or cold away, it'll still hurt for a minute, but it'll eventually go away. Now, if you got stabbed with a knife and then you remove the knife, you're probably going to still be in pain. I've never been stabbed, so I can't speak for firsthand experience. This pain is going to be localized to the area of stimulus. So unlike C fiber pain, with A delta fiber pain, you're going to be able to know, even without looking at it, exactly what part of your body is hurt. You feel it, you don't mistake it with anything else. This is usually not associated with emotional involvement, believe it or not. This can be very, very painful, but this is one of those types of pain that we can get really, really hurt, but at first we don't really feel the pain, or we feel the pain, but after a little while we start to get a little used to it. That would be our own natural body, endogenous system taking over to help with the pain. But yeah, it is kind of funny. This can be a really bad type of pain, but it's usually not associated with emotional involvement. Now, that's not to say the person can still cry and scream out in pain at first. I mean, I think if I got stabbed, I would probably scream bloody murder. That's just me thinking, but I don't know. But here's something else to remember. A delta fibers cannot be blocked by opiates. So if you get pain, and if you get damage to your A delta fibers from an injury like that, they're more than likely not going to give you opiates for that type of pain. So sorry. This is just a little, this is a just kind of a little drawing of C fibers versus A betas. The only really difference is you can see the myelin on there and the speed. Okay, so now we have a third type of fibers. This is not to be confused with A delta. These are A betas. Okay, so sorry to be giving you all these terms. A beta fibers are large and myelinated. So they're larger than C, they're larger than A delta, and they transmit pain quicker than C and A delta. Okay, these are located in the skin, the bones, and the joints. And if you think about it, if you have pain in your bone, skins, or joints, that's pretty much what you want to know that pretty quickly, because if you're getting something going on in your skin or that might affect your joint pretty quickly, you want to stop that whole whatever's going on so you can stop that damage and prevent further damage. These normally transmit sensation related to vibration, stretching of the skin, and mechanoreception. Mechanoreception means knowing where your joints are in space, knowing where your limb is in space, knowing that, like, I don't have to open my eyes to know that I'm holding my arm straight up in the air. I don't have to open my eyes to look that my fingers are curled, and now I don't have to look to know that I'm straightening and building my elbow. We have nerve fibers inside of our joints, which are called A betas, that let us know that. Okay, so those are actually sensation fibers that let us know where our body is in space. It's in our skin, so we can know when our skin has been stretched out, when it's been folded, things like that. These are not normal pain transmitters. These are what we call A betas, or what we call non-nocioceptive cells. That means they feel things like pressure and stretching and mechanics and reception and vibration and things like that, but these are usually not related to pain. These are so where we know our body is in space, so we can be in control of our body at all times. These are very, very important. They can be involved in abnormal pain transmission and perception, especially with long pain. And if neuropathic pain is involved with an A beta fiber, it can result in the central hypersensitization, where normal sensory stimuli will become painful. Any questions on the different fibers before we keep going? Okay, so I know there's a lot of different characteristics of the fibers, but you just have to know them. So you've got, remember, you've got C, A delta, and A beta. So you got 3 fibers you need to know. They're all a little different and they all do different things. So make you a little chart instead of trying to memorize this PowerPoint word for word. Okay, now we're going to talk about T transmission cells. Okay, so there's a few different kinds of cells in the body that are called T cells sometimes. A lot of times in the immune system, when they talk about T cells, they're talking about your white blood cells and your autoimmune cells. And when we're talking about the spinal cord and pain, we're talking about T cells, and we're calling T cells transmission cells. These are totally different types of cells that live in the spinal cord, okay? Basically, what the T cells do is they either allow the C fibers to activate and let you feel the pain, or they get input and inhibitory input from fibers in the brain, and then they tell you not to feel the pain. So let's look at a picture. So let me look at this picture. Whoops, a little bit closer. Where are the T cells? Let me split this. Nope. Okay, so just follow my mouse. Here's a C fiber. Whoops. Here's a C fiber. Here's an A delta fiber. Okay. Well, then here, living in the spinal cord, you've got a T cell. Well, the T cell, think of it as what we call a transmission cell. It's going to allow the body to either feel the pain or not, okay? So the transmission cell is actually getting signals from the brain to say, I'm going to feel this pain that's coming through from the periphery, or I'm not going to feel the pain that's coming through from the periphery. So this is one of the theories that they think that sometimes we can have like an injury, such as like we can break a bone and the bone might be sticking through our skin, and we might just be sitting there and know what's going on, but we're not crying, we're not freaking out. We just know, hey, I can't get up. Or we have a really severe injury and we know the injury, and people around us assess us and know the injury, but we just barely feel the pain. That's your T cells helping you not feel that pain. They're kind of like they kind of help us out so that we don't get overwhelmed with pain. T cells are our friends. So this last bullet, look at this last bullet. Let me explain it. It says it receives excitatory input from the nocioceptors, that means on the peripheral part of your body, and inhibitory input from the sensory nerves and descending fibers from the brain. So the brain is inhibiting that sensation from being felt. Those are your T cells. Okay. There's also something called the pain spasm pain cycle, which can be activated by T cells, and this is actually not a really good thing to happen. This can happen if you have this can happen if you have an injury and then you have muscle spasms and pain at the same time. If the muscle spasms are causing more pain, that's going to cause additional muscle spasms. Then you're going to have to get modalities or muscle relaxants to decrease the muscle spasms. Because if you don't decrease the muscle spasms of an acute injury, you're going to just cause more damage and more tissue damage to that area. So you've got to stop that cycle. So the pain spasm pain cycle can happen when the T cells are overactivated, and instead of inhibiting the pain, they're letting the muscles have spasms in response to the pain, and that builds up tissue and cell irritants, okay? It's kind of hard to understand. Just know it's a cycle and you want it to stop. And we can stop that cycle. Just a picture of it. Okay. Any questions so far? We're going to jump to the sympathetic nervous system next. This is still explaining a lot on pain. So we're not really changing subjects completely. Okay, so the sympathetic nervous system. So our central nervous, well, we have a sympathetic nervous system and an autonomic nervous system. The sympathetic nervous system is our fight or flight activation system. So when we feel pain, hold on, what does this mean? Well, so the sympathetic nervous system can be activated by acute pain or injury, but it does cause some pain. Right here, I don't know why that says does not cause pain. It should not. I don't know what I was thinking when I put that not in the pain. It should be does cause pain. Okay, so activated by acute pain or injury causes pain. Then you have a hyperactive response or failure of the response to subside these. So two things can happen. The pain can either increase in severity really quickly. We can have an increase in sweating and bodily reactions, and we can have an increase in vasomotor reactions, which means vaso is our venous system. So our arteries and veins are going to dilate at first to bring more blood into the area, and then restrict blood flow to the area. Okay, so we're going to have those reactions. We can treat a sympathetic nervous system response with chemical or nerve blocks. And those are usually injections into the nerve. Once you have this hyperactive response of the sympathetic nervous system, it basically is kind of there with you and it doesn't really go away. So a normal sympathetic nervous system should feel pain quickly and then it goes away when the cause of the pain goes away. But then if the system is hyperactive, or the response, the severity or the pain response doesn't subside, that can develop into these more chronic pain issues, which are called down here at the bottom, where it says other names. We have RSD, which is reflex sympathetic dystrophy. We have causalgia. We have post-traumatic dystrophy. And those are all old names. The new term for an overactive sympathetic nervous system is called CRPS, Complex Regional Pain Syndrome, or you'll hear us say it Crips, because if you look at the initials, it spells Crips, and that's a lot easier to say than Complex Regional Pain Syndrome. This is where this often happens, and this can happen to anybody, but this often happens when somebody has had an injury usually to a limb, and it's almost usually an arm, and then they don't want, because of the pain, they don't want to move this arm for a while, or they keep getting their nerve blocks for pain and they keep taking their pain medication, but they don't they may be going to therapy, but they don't follow through with therapy. So they're never doing their stretches. They're never doing their strengthening that they need to do, whether it's passive or active. So even if it was passive, we could keep this hypersensitive activation of the nervous system from happening. But because they protected it and too long and didn't use that part of the body, they're going to become very hypersensitive. And that's when they'll develop the Crips. And that's very hard to get you rid of. Not impossible, but very hard. So let's talk about more signs and symptoms of Crips. So it's severe pain way out of proportion to the injury or the disease, okay? So it's hyperesthesia, hypersensitization. It's just any sensation that they feel. It can be real pain. So if they got, say it was in their arm and they got poked with a needle, or their cat or dog came up to them and tried to sit on them and they got poked with their claw, which say maybe dull, and it normally that would just be a little, hey, get off of me, that hurts. But to them, that's going to be like blowing their arm off their body or catching their arm on fire. It's going to be the worst pain they've ever felt in their life. I've even heard of people that just putting on a shirt, a pullover t-shirt, or just putting their arms through their coat sleeves is so painful that it just takes, because it's like fire going on their skin. It can become so painful. That's eventually called allodemia. That means pain from a non-painful stimulation. That is not completely irreversible. It does take a little while to get reversed, but we'll talk about that later on, how you can reverse that. It can cause some changes in your skin and in your muscles, what we call trophic changes. And if you remember, if you were in medical terminology with me last semester, trophic means development or developmental. So trophic changes can be like skin atrophy. So people with CRPS can have their skin shrink or get thin, usually really, really thin. Even if they're not an older person, their skin can get really thin. Hyperhidrosis, they're going to sweat a lot on that body part. They tend to keep edema there. They tend to stay a little bit swollen there. They're going to be stiff in those joints, so that joint. And this is a place where some of us disagree. I've seen decreased hair growth on a limb with CRPS, but Dr. D has seen in home health increased hair growth on a limb after CRPS. So those trophic changes obviously can go one way or the other, because I've seen a few stroke patients that had CRPS developing in their arm, and they had shiny skin that was greasy and sweaty, and the hair was falling out. But Dr. D has seen several people with CRPS where they had more hair growing on that limb. So I guess it can happen either way, but she and I have both seen different things. So any questions on the sympathetic nervous system, hyperactivity, CRPS, how all that works and changes before we move on? Throwing a lot at you. Okay. Next. Okay. Now we're going to talk about a way that we normally block our own pain. And it's a pretty cool way that we do it. We don't even realize we're doing it. Okay. There's a couple of different ways that sometimes our body will stop the pain before our brain can feel it. Okay. So there's one of these that's called the gate control theory. And that simply says that if we induce a non-painful stimulus on our body, then we can block the stimulation of a noxious stimulus. So if we stimulate a non-painful stimulus, we can block this transmission of a painful stimulus. Okay, so an example of that, think about, we've all done this before. You knock your elbow and you hit your funny bone. Now, I don't know if you've learned this yet, but you're actually hitting your ulnar nerve that runs right through your elbow. Well, when you hit your funny bone or your ulnar nerve, we know that hurts. It doesn't feel funny. It's not really, it's painful, but it's real tingly, and it just feels the weirdest stimulation you have ever felt. It's just an odd feeling. Well, you may have done this before, but never really realized this. But next time you do that, or next time you bump your knee or do anything, try this. Take a hand and just rub that area slightly, not with a little bit of pressure, not too much pressure, but just rub it, okay? And just about the speed that I'm doing now, put your elbow or your knee, just do this. If you hit any other area, just rub it. If you hit your head on a wall or something, I don't know why you hit your head on the wall, but just rub your head. That is stimulating non-noxious nocioceptors. So what we're doing is we're stimulating non-painful nocioceptors to block the transmission of noxious nocioceptors. And a lot of the times it works, okay? So how does this work? In the spinal cord, there's an area called the Substantia Gelatinosa, and it's in the brain. Well, here's your nerve fibers coming in. And so you should be feeling all these nerve fibers are going up to the thalamus and then to the cerebral cortex. But let me see what the next picture says. If we can stimulate these A betas down here by rubbing or putting a little pressure or putting compression on an area, like with ACE bandages or a compression sleeve, that can a lot of times help get rid of the pain. So I dare you, the next time you bump anything, I mean, we're all always running into something or bumping our elbows, bumping our knees on a coffee table, or bumping our hip on a chair or on a table. Try that. Just if it hurts enough to where it makes you go ouch or feel the pain, rub it with your hand for a few minutes and see if that feels better. It should automatically make it feel better. So what's happening is that they say that when we are rubbing the skin, we're activating the A beta fibers that are going to inhibit the transmission of C and A delta. So electrical stimulation, traction, compression, massage can all activate those non-nocioceptive sensory nerves. So that's also a way we can help with modalities with getting rid of pain, is with E-stim, with traction and compression and massage. But we're going to learn all about those one by one in the upcoming weeks. So don't forget what the gate control theory is, because it's going to come back to haunt you. Okay. Now, another pain control method of our body, endogenous opiates. So endorphins, we've all heard endorphins before. That's like, you've heard of the runner's high. That's our natural painkillers that after we exercised a lot or we've done a lot of physical work, but especially after running or exercising a while, you feel tired, but a lot of times unless you've exercised to the point of exhaustion, you feel good, like you want to keep going, or you get that runner's second wind where you've been exhausted and then you get a second wind. Those are your endorphins and your endogenous opiates, okay? So they actually are opiates that our body makes that are the same structure as opioids that come from the poppy flower and other plants that make opioids. So our brain and all through our nervous system has receptors for opiates and in our endogenous opiates. So whether they're made from the plant or from our body or synthetically. So they're found in peripheral nerve endings. You don't have to know these three different kinds, the metaenkephalins and the leuenkephalins. This says produce effects similar to morphine, because morphine is a drug that is made from opiates. So that's why your endogenous opiates can make you have morphine effects. Obviously not as strong as taking morphine, but it's going to help you get rid of soreness and get rid of pain while you're running or while you're lifting or while you're exercising. If you're in the hospital and you may have one of those morphine pumps after surgery, you can punch that button and it'll time it to where you can give yourself a little bit of morphine and it'll give you some pain relief. Because it'll give you a little bit of that medication, and then it'll go through your body, and then the molecules of the opiates will bind to our opioid receptors in the body, and then we'll feel less pain. Besides being in the peripheral nerve endings, endogenous opioids also inhibit the release of substance P from C fibers. If you remember, substance P is always what the damaged cells release. And it inhibits the activity of A beta fibers. So endogenous opiates, those molecules and those medications inhibit the activation of C fibers and A beta fibers. So that's why opioids work on them, but not on A delta. If you go up here and remember, so if you remember, A delta, not blocked by opiates, but C and A beta are blocked by opiates. Now let's see if I can get where I was. Okay, this is the next line. Endogenous opioids help modulate and control our pain during times of emotional stress also. So things that would make us pain that would make us cry or freak out or things like that, they actually make the pain threshold increase. And what that means, we might actually still be feeling the pain if it's something that bad that's going to make us that emotionally stressed out and freak out, but it's going to make our threshold of pain increase, the opioids will, so that we still feel the pain, but it's not going to feel as bad to us. It's not going to be as upsetting, and it's not going to be as physically, it's not going to cause as much discomfort. The pain, you're still going to know the pain is there, but you're going to be able to deal with it a lot better. Our endogenous opioids are there to help us deal with that. So people that have terrible injuries and just are conscious and pulled from the wreckage of the car and taken away and are just fully conscious but have terrible injuries, their endogenous opioids are on overdrive just to keep them from going. I mean, it might make you go insane if you didn't have all that, if you felt all that. I don't know, I'm just saying. Helps to explain the endogenous opioids act a lot like acupuncture. So whenever people get acupuncture or dry needling, we are stimulating the release of endogenous opioids. And when we do TENS, transcutaneous electrical nerve stimulation, we can also release a certain type of TENS. Where it says noxious TENS, don't think of that as, it shouldn't be noxious TENS. It's really TENS that makes muscle movement. That usually will release our endogenous opioids too, and that'll help with pain relief too. There's a high rate TENS and a low rate TENS. It's usually low rate is what you want to make to release your opioids, but sometimes it's a little bit more painful, so not everybody can take it. But we'll learn the differences in those later. Okay, pain scale. We always measure a person's pain on some kind of scale. Okay, so these faces up at the top, this is a visual analog scale It's called the visual analog scale. And the faces are made as a pediatric pain scale, because kids can't give you a number 1 through 5 or 1 through 10 on how bad their pain is, because that's too abstract of a thought for them. They can't say, oh, my pain's about a 6 right now, but it was a 7 yesterday. They can't come up with abstract thinking like that. But if you give them a face that correlates with a number, and with kids, we don't go 0 through 10. We just go 0 through 5 and they start off as a smiley face, and then it gets less happy, and then it gets frowny, and then eventually hurting a lot is crying. That's what we show kids. With people, we can give them this line over here where there says no pain on one side and worse pain on the other side, and they can put an X or a line, or we can just do the easiest thing and just say, can you tell me what your pain is on a scale of 0 through 10? Remember, it's 0 through 10, not 1 through 10, because 1 is pain. 0 would be no pain at all, I'm totally fine. Okay? Here's some tips. Never say to your patient, how is your pain today? Or tell me about your pain, because they are going to give you a long story that's going to take 10 minutes, and it's going to be way more detailed than what you want to know. Just ask them a few things, and don't give them the option of having pain either. If they're a patient that's been coming to you for, say, just cardio endurance purposes, and they don't really have any pain anywhere, they're just seeing you to get stronger. Well, don't ask them about if they have any pain every time they come in, because maybe they're going to start looking for pain, and that's going to just add more things onto their plan of care. And if they start thinking about, do I have any pain, they're always going to find it. And that's the power of suggestion on anybody is very, very strong. So you can ask a regular adult or a kid every single time you see them, do you have any pain today? Where's your pain? Eventually, they're going to have pain somewhere if you keep asking them. So just ask them, if you know that they're having usually pain, what's your pain today, 0 to 10? And then ask a little bit more about their pain. What does it feel like? Is it aching? Is it sharp? Is it dull? Because that'll let you know, is it acute pain? Is it chronic pain? Things like that. You can give them a body diagram, which is just a front and back picture of the body. And you can tell them to draw where they feel their pain. So that's what these different things up in the corner mean. You can put a draw where the sharp pain is. You can shade in different parts of the body where there's tingling. You can put like shooting pain with like a zigzag. It can be however you want to color it in. It can be dots, it can just be X's. You can use different colors to mean different things. Just however, and you can do that in the PT can do that as they're filling out their paperwork before their eval even starts, so that before the PT and you even see the patient, you can look in their chart and you can get a diagram that they have filled out on where all their pain and symptoms are. So that's pretty good. That's a pretty good thing of information to have. Pharmacological management. So a lot of people are going to take meds, obviously. Systemic analgesics, which means that go in the whole body, which means systemic analgesics circulate through the whole body. So that's what you usually want first. So I talked about NSAIDs. That's like ibuprofen and aspirin. Acetaminophen is Tylenol. It's not it works just like an NSAID, but it works a little bit different chemically. So that's why it's not called an NSAID. Opiates and opioids. Antidepressants have anti-panic effects, and some antidepressants have different different effects on chronic pain also. Spinal analgesia would be like a spinal block. So like if a common spinal block is like an epidural, or a local injection would be like an epidural, where like if a woman is going to have a cesarean section, or she's going to give natural childbirth but wants to feel less pain, she'll get an epidural around her spinal cord, which is a local injection, or a spinal analgesia, which the medication will only affect the body or the nerves from that where it was given distally. So that's why in an epidural for giving birth, they give it to the lower back, so then you have pain control from the mid trunk down. It doesn't spread to the upper part of your body. Or if you just need a local injection, like a shoulder injection or a nerve injection, that would be better than a systemic injection, because you don't want to get it all over through the whole body. You want to get it just to that one place. Physical agents control pain by doing all these things. They release the influence of inflammatory mediators and substance P. They modulate pain at the spinal cord level using T cells and the gate control theory. They alter nerve root conduction. Remember, we'll talk about that later. Heat speeds up nerve conduction velocity. Cold slows it down. Physical agents can increase endorphin levels. Heat speeds it up to let us release more. Cold lets us release less. Decreasing the sensitivity of muscle spindles with cold will help with muscle spasms. So if you're in that pain cycle, then you need cold to stop that activity of muscle spasm. Modifying vascular tone and flow with cold to help with pain, and reducing edema or ischemia with cold can all help with pain. Okay, so before we take a break, a much needed break, any questions about pain? I know there are, especially the different pain mechanisms and theories and cells. Any questions or anything you want me to repeat on those? There's got to be. Okay. Well, okay.
If you could kind of go over the nerve fibers, like
I can go over
fibers, delta and beta.
Sure. That's usually what people want to go over anyway, so that's what I was waiting on. I read y'all's mind. Okay, so we'll start off with C fibers. Now remember, C fibers are afferent nerve fibers. They're ascending, which means they go from the periphery of the body up to the brain. Okay, so these are sending pain signals to the brain, letting the brain know, hey, something's going on down here. Okay, so they make up 80%, and they're small and unmyelinated. Okay, so they have a slow transmission of pain. They respond to mechanical, thermal, and chemical stimulation. Okay, so things like getting poked in the skin, thermal, feeling cold or heat stimulation, it's going to be slow, 1 to 4 seconds. Going to feel the pain is going to be dull, throbbing, aching, or burning. And sometimes it's going to come on immediately after the stimulus, but a lot of times it's a slow onset. So the pain tends to get worse as maybe the next hour goes on, hour to two goes on. It's long lasting. So even after the cause of the injury is taken away, you still feel the pain. It does cause emotional difficulties. And it's diffusely located, so you feel it kind of a little bit, it's spreading everywhere. Causes sweating, heart increase in all your vitals. Respiratory rate, and can make you nauseous too. And pain, and these can be and C fiber activation can be reduced with opioids. Okay, A delta fibers are small but myelinated, so they're faster than C fibers. They make up about the remaining 20% of ascending pain fibers. And they respond to high intensity mechanical stimulation or hot or cold. So these are, so while C fibers can respond to mechanical, hot, and chemical, A deltas are responding to very, what you would call super high intensity mechanical heat or cold. So maybe like not just getting bumped into somebody or feeling pressure on you or feeling something hot or cold on you, but actually getting burnt by something hot or cold, like touching a hot pan or a hot stove, or getting burnt by getting splashed or something by a grease cooking, or getting splashed with a strong chemical or something that will burn you. That's what, an A delta is going to pick up. High intensity mechanical stimulation. Sharp, stabbing, prickling, quick onset of pain. You're going to feel it immediately. Think about if you get popped with hot grease when you're cooking, or you touch a hot pan, you don't just touch it and then go, oh, that pan is hot, and then take your hand away. No, you touch it, and then within milliseconds, I mean, you don't even have to think, by the time you've already jerked your hand away from the pot, that's when you're thinking, oh, that pan was hot, and I didn't even have to think about jerking my hand away. Well, these are not blocked by opioids, okay? These are quick, last short amount of time, not blocked by opioids. So it usually can go away as soon as you take away the problem. A betas are large and myelinated, and they're quicker than C and A delta. These are not pain transmitters. They're not nocioceptors. They're non-nocioceptors, okay? So they're going to be responsible for things like, abnormal pain transmission, with things that are more prolonged pain. So these are, a beta will feel all of the things, but they'll be more likely to help you, if you start feeling the A betas, to develop more long-lasting hypersensitization. So you usually don't want to get to the point where your A betas are feeling your pain. These are later. Okay, see the central pathways. T cells are in the spinal cord, and they're inhibitory, so they may inhibit the pain from coming in. So they live in the spinal cord, and they can inhibit the pain coming in from A deltas and C fibers. We talked about the pain spasm pain cycle. Pain spasm pain cycle is caused by the T cells. They're just causing increased motor reactions and spasms. So the more spasms you have around an injury, the more edema you're going to create, and the more cellular irritants and substance P you're going to release. So the further injury you're causing. So if you're stuck in that pain spasm pain cycle, it's really going to slow down your healing process. So we've got to slow that down, and you'll learn this later, but with cold, with electrical stimulation, and with pressure. Then we talked about Crips. Then we talked about the gate control theory. Which is basically stimulating an A beta fiber by rubbing your skin or providing pressure or E-stim or warmth or cold to decrease or inhibit the transmission of the pain cell completely. Then we talked about endogenous opioids. And we talked about our pain scale. And that was it. So any other questions on pain? Okay, like I said.
I have a question.
Okay.
Just out of curiosity, which one would be related to like phantom pain?
That's neuropathic pain.
Neuropathic?
That is definitely neuropathic pain. And I would say if you even are asking what nerve type it is, let's go back. It's most likely going to be probably your C fibers, because they're long lasting and can be reduced by opioids. So people that have like amputations that have a lot of neuropathic pain, a lot of times they are on pain medication for either for a few years while they're having their neuropathic pain or for the rest of their life. But a lot of times they're not going to put them on opioids because we all know how addicting opioids are. And then you just need more and more and more and more and more. And then they just mess up a lot about your brain. A lot of times they're on nerve pain medication. The most common type is called gabapentin. It's specific for nerve pain, and that helps a lot with phantom pain. And they give gabapentin to other people for types of pain too, but for amputees, gabapentin is the most common type of pain med. Any other pain questions? All right. So let's do this. Let me look at one thing. So we've got another lesson. Let's take a 10-minute break. Well, yeah, let's take exactly a 10-minute break. So I've got 9:56. So let me stop recording or okay. Use the size hot pack to fit the right size of body. So if you need a big hot pack, if you need to heat the whole back, use a big hot pack. If you have a small area of the body like the knee or the elbow, try to use a smaller one. Deeper tissues, less affected by heat than superficial tissues. Okay. Convection, we will not be using a lot of convection modalities, but hot whirlpools are a type of convection. If you've ever heard of Fluido Therapy, where you stick your limb in a vat of usually crushed up cellulose, which is like it'll be different. It'll be like sawdust or crushed up corn cobs or plant material, and it'll be finely ground. And then they'll blow hot air through all that, and it'll blow hot air and all those plant materials, sawdust, all around your limb, usually just your arm, and it can help with pain reduction and help with range of motion and blood circulation. Just read through conversion. We'll use ultrasound as a conversion type of heat. And we will talk about radiation a little bit. We will talk about evaporation a little bit. Okay, but let's talking about what thermotherapy is used for so you can know what it is. It's the therapeutic application of heat. So heat. Used for pain control, increasing soft tissue extensibility or flexibility, increasing circulation, and accelerating healing. So how does it help? It causes vasodilation, so it brings more blood flow to the area. So it can bring more nutrition to the area, and it takes away waste products from the area. And because there's more blood flow, we can also dissipate some of the heat in the area. It can, heat increases nerve conduction velocity, so it'll make nerves conduct their action potentials a little faster. And it'll decrease the rate of muscle spindles firing, so it'll decrease the DTRs or the reflexes just a little bit. And it will give you an increased pain threshold due to the spinal gating. So it's the gate control theory where we're stimulating non-nocioceptors, which are the thermoreceptors, or for heat, so we won't feel the pain. Please read this. There will be decreases in muscle strength during the first 30 minutes after application. Treat only the area that needs to be desired. Okay, this is a nice little chart to help you see what goes on. Okay, what happens with heat? The effects of heat. So you have increased metabolic intake. So you're getting more nutrition and oxygen into the cells. I already said decreased oxygen uptake, which is going to make you heal faster, and increased destruction of articular cartilage in some patients. So patients that have rheumatoid arthritis, we shouldn't use a lot of heat with them because that can actually cause further destruction of their arthritis. Now, if they have osteoarthritis, which is the more common type, we can use heat with them all day. Alter tissue extensibility. So this heat increases collagen and flexibility. So before you're going to really do a lot of stretching to somebody, you may use some hot packs or heating on them, so you decrease the risk of tissue tearing. Indications of heat: chronic, subacute, or chronic inflammation. Never acute inflammation, but chronic inflammation is okay. Chronic pain, chronic muscle spasm, decreased range of motion if they're tight. To resolve a large hematoma on the surface, you can use heat. And reduction of joint contractures where the joint is stuck, you can use heat to loosen it up. Superficially, the skin increases are going to increase to about 104 to about 113, and that's going to go down to about 2 centimeters in depth into our tissue. Okay. So anything deeper than 2 centimeters is going to have to be done with a deeper heating agent. So the moist hot packs that we use, the hot packs that we use with covers like in the clinic that you're used to seeing, those usually only get down to about 2 centimeters in depth. We have to use other machines to get down deeper than 2 centimeters. And we'll get there later. So superficially, moist hot packs, paraffin baths like the wax that you get at the manicurist, we're going to use the same things. Warm whirlpool, or just warm water immersing your limb in the warm water. Infrared would be like lasers, which we'll talk about at the end of the semester. Deep heating agents, which would be the ultrasound, which can go down to 5 centimeters in depth in your tissue. And diathermy, which is a electromagnetic type of heating, which we'll talk about at the end of the semester. Not used as much these days. Pain control heat works on the gate control theory, reduces sensation of pain by altering nerve conduction. Psychological, it's relaxing and can influence our perception of pain. But heat should never be used with acute injuries, as you'll see next. Okay, heat increases range of motion. Especially with a low load, prolonged stretch. And that means stretching, don't stretch the person to their limits, to their screaming, but you heat somebody up for 5 to 10 to 15 minutes. And then you give them a light stretch, but you might hold it for 2 minutes. So giving a low stretch where you're stretching just a little bit, but holding it for a longer amount of time is far more beneficial to stretching and getting more range of motion than doing a maximal full pressure stretch for only like 15 to 30 seconds. The longer you hold it, the better off you're going to get. And there are studies that show that when you're stretching, you don't get any tissue lengthening that's going to be permanent until you hit 60 seconds of stretch. So you might as well stretch for 30 seconds times 2 or 60 seconds. But it's got to be a bearable stretch. It can't be too painful. Decrease joint stiffness by increasing the elasticity of the joint. Accelerates healing. I've said all this. More oxygen, more nutrients, removes waste products. Okay, contraindications for heat. This is important for you to know. If there's been an acute injury or there's acute inflammation, you can't use heat. If there's been a recent hemorrhage anywhere in the body, you don't want to use heat because you could open that hemorrhage back up and it could bleed internally more. Thrombophlebitis is a blood clot. You don't want to use heat in that area because you could break up the blood clot and send it to another part of the body and maybe cause death. If they have impaired sensation in that area, or they can't feel enough, or they can't feel the same as they used to, you either don't want to use the heat or you want to check on their skin every few minutes just to make sure you're not burning them. Malignancy, if there is active cancer in the area, you don't want to do it. You don't want to use heat over open wounds. And if a woman is pregnant, you don't want to put heat to the lower back or the abdomen because that could affect the baby, obviously. Okay, now these are not contraindications for heat. These are just precautions that could be contraindications. So again, acute injury or inflammation, that's more of a contraindication. Pregnancy, yes, it's a contraindication if you do it around the lower back or the abdomen, but if it's for like the shoulder or the knee, that's probably okay. Just get permission from the doctor. Impaired circulation, you usually don't want to use heat. If there's edema in the area, unless it's chronic edema, you don't want to use heat. If they have a cardiac insufficiency, anything to do with low cardiac output or congestive heart failure, you don't want to use heat because you're just putting more of that edema back into the bloodstream, and that's just more fluid the heart has to pump, and it's just more work on an already damaged heart. Metal in the area can be okay as long as it doesn't heat it, like say if a person has a knee replacement and you need to put a hot pack on them to get them stretched out, you can put a hot pack on them, but just make sure that their knee doesn't heat up too fast and give them pain, because that metal can heat up a little faster than their tissue. Never over and open wounds. If you've had any topical medication put over your skin that day, you don't want to put it over that, even if it's just an itching cream, because it can cause a reaction. And anywhere where you've got demyelinated nerves going under the skin, you don't want to put a hot pack over that. Adverse effects, cell death from being on too long or too hot. Not using enough insulation. You always want to use 6 towels for insulation, or 3 to 4 hot pack covers, which we have in the modality room hanging up. Their hot pack covers are twice the thickness of a towel. So you can use 6 towels for your 6 to 8 layers of towels for your insulation between the hot pack and the patient's skin, or 3 or 4 hot pack covers, or a combination of the two, whatever makes 8 layers. Sometimes fainting can occur. I've never seen it. I've never seen bleeding. If you're bleeding, you are probably over an open wound, and you shouldn't have done it over, you probably shouldn't have heat over it anyway. Moist hot pack. Stored in hot water tank. You need to know that temperature range. Take 6 to 8 layers of towels or 3 to 4 layers of hydroculator pads between the hot pack and the skin, and you leave it on for 15 to 20 minutes based on the size of the body area and how much fat tissue is present. So general rule is 15 to 20 minutes. Okay, so these are the different, these down here in the lower corner of the screen are the different sizes of hot packs that we have, all different shapes. Oops, I didn't mean to go up that much. These are the hot packs that are wrapped in some of the insulating layers. Now those are not enough layers, but that's what they look like. And these are the different size of water tanks that they stay in. And ours is much bigger than this. Paraffin wax is the same type of wax they use at nail salons. You do need to know this temperature range. It's really good for heating hands and feet because they're very irregularly shaped areas. So you can dip your hand or foot in the wax, or you can paint it on there. Either way, after it's hardened on there, you wrap it up in a plastic bag and a towel, and you keep it on there for 20 to 30 minutes. And these are special gloves that are shaped in the shape of feet or hand mittens, but we just use regular towels and just wrap the hand up. It doesn't have to be a special, that's just a regular towel made into the shape of a foot. And this is the exact type of paraffin bath that we have. We have 2 of those. Fluido therapy is the dry therapy I was talking about with the corn cobs or the sawdust. This is what it looks like when your arms are stuck in it. Infrared is done with lasers or lamps, and we'll talk about those later in the semester. Okay. Oops, I got an error. Don't know what that means. Whoa. Can y'all see my PowerPoint still?
Yes.
Is it? I hit a, there it goes. Y'all see it now, magnitude of heat application?
Yes.
Okay, because it went away from me. So obviously, if the temperature is too high, then pain and burns are going to occur. If the temperature is too low, the body is going to dissipate its own heat, and nothing's going to happen. So you got to make sure that your hot pack has been in the water for at least 30 minutes heating, and that your paraffin is at the right temperature. So for the first 5 to 6 minutes, the body is going to absorb heat fast. 7 to 9 minutes, it's going to tissue temperature stabilize with getting increased blood flow. And then at the 10-minute mark, subcutaneous tissue will be heated up. And then at 15 to 20 minutes, you'll have muscle tissue heated up. And you should never go more than, where this says superficial intramuscular tissues remain elevated for approximately 30 minutes after treatment. That doesn't mean leaving it on for 30 minutes. That means if you've left a hot pack on for 15 or 20 minutes and warm the muscles up, they'll stay warmed up for about 30 minutes after you remove the hot pack. Know these temperatures. Documentation. This goes for cold too. Area of the body treated. Type of heat used. Temperature, if you knew it. Number of insulation layers. If you used a special machine, distance from the patient. Patient position, always, and how long, duration is how long you did it. And then response to the intervention. Did they have more increase in range of motion? Did they have decreased pain after the intervention? Whatever. Okay, so I know I had to fly through that, but now we have to get through cold before lab. The good thing about flying through, having to go through these quick, is that the lab is just on hot and cold on Wednesday and sensory checks, and you've got videos for all those things already. So if you haven't watched them, I've got the links up on YouTube, so go for them and watch them. They're very, very well thorough and thought out. Okay, let me bring my cold one up. So we've got 10 minutes to go through cold. And I don't know where it went. Okay, do y'all see it now? Thermal of agents cold?
Yes.
Okay, so just remember this. You may notice this in the name. Thermal agents include hot and cold agents, okay? So when you see thermal agent, it can mean hot and cold. If you see the word cryotherapy, like it says on the slide, that's only for cold, okay? Okay, so cooling is to control inflammation, pain, decreases edema, decreases spasms, controls symptoms of MS, which you'll learn later. Okay, so when you have an acute injury, that's a new injury, that's when you want to use cold, okay? So you want to decrease the blood flow so it can stop taking away, so it can stop releasing so much substance P and everything. And you want to slow down the sympathetic nervous system just a little bit. So you want to slow down the circulatory rate. This is all what's going to go on with a temperature decrease to decrease blood flow. Okay, so you're going to have vasodilation, decrease blood vessel diameter. So it's going to bring blood vessels smaller. Okay, it's going to decrease nerve conduction velocity. So it'll slow down the action potentials. And for the A delta fibers, which are smallest and unmyelinated, those are the most affected and responsive to the cold. And these also help increase your pain threshold by working at the gate control theory. So these stimulate the cold nocioceptors of your body, and so then your body eventually won't feel the pain anymore. Effects of cold, it's dependent on totally the timing and how much you used it on. You will have a little bit of decreased muscle force degeneration for about 30 minutes after cooling, but it's back to your regular strength after an hour. Spasticity is something that happens with people that have neurological injuries, but for now, let's just use it as the word spasm. Let's just leave it at that. If you're working in that, if your patient is in that pain cycle, you can give them a cold pack to reduce those spasms so it can reduce that cycle and can reduce their pain. And it can last for up to an hour and a half. And where this says, facilitation of muscle contraction, that's only used in the neuro world. And that wouldn't be putting ice on somebody like an ice pack. That would be like, if I cannot get my bicep to fire, I might take a big block of ice and just real quickly put it on my bicep and then really quickly relax it. And it's supposed to be the shock of the cold that's supposed to make me contract my muscle. Doesn't always work. Sometimes it makes spasms worse, but it can work. Okay, metabolic decreases, helps decrease acute inflammation. So acute inflammation is always cold. So after an injury, you always use cold, and inhibits activity of cartilage degrading enzymes. So that's really good. Okay, so other uses: inflammation control, edema control, pain control, spasm control, and cryokinetics or cryo stretch. We'll talk about that later if we even get to it. Okay, decreases the tissue temperature, slows the chemical reactions that are occurring during the acute inflammatory response. So the acute inflammatory response is making a lot of heat, redness, edema, pain, and loss of function. And cryotherapy is going to help reverse all that or slow it down. It's recommended that cryotherapy be used immediately following an injury, and at least for the first few days until the swelling starts to go down. And this last bullet is just an extra DOMS, DOMS, that stands for delayed onset muscle soreness. That's the muscle soreness you feel after you've worked out and then you wake up and you're sore the next day. So this is saying that if you use cold therapy and cold packs, or like cryotherapy, cold body cryo tank after a hard exercise, it can actually delay the symptoms of delayed onset muscle soreness. I guess if you're too much of a wimp to go through that. Let's see what this says. So when the goal is to increase inflammation, you want to generally keep your time limited to only 15 minutes, because that's because you're reducing the circulation so much. You don't want to reduce it any more than what you did in the first 15 minutes. Okay. Okay, I've got 5 minutes left. Edema control. For edema control and swelling, cryotherapy is most effective if you compress say if you rolled your ankle and your ankle is swelling. Well, you can put an ice pack or ice bag on your ankle, but it's going to be best effective if you elevate your ankle so that the swelling will have gravity to help it. And if you compress it like some compression wraps or ACE wraps, that'll all three help them get it out the most. But the edema is really doing a lot of the job. The elevation, just use gravity to your advantage. It'll help a lot too. This is what you want to actually do after an injury. It used to be called RICE, and now we've added a P to call it PRICE. So you protect, you rest the area, you cease further activity, you use ice, you use compression, and you elevate it. So that's what you do after an injury. Cryotherapy is not effective in controlling edema that's a result of immobility or poor circulation. So if people can develop edema in their arms and legs from just being immobile and being sedentary and just sitting all day long, if they're those kind of people, cold therapy is not going to help that kind of edema. And if they have poor circulation, which is making them get edema in their lower legs, or if they've got lymphedema because they've had mastectomy and they've had one or both breasts removed and they've had lymph nodes removed, then their arms are going to get really big and swole up. And that's a big problem. That's a whole different type of edema. That's a whole different animal right there. Cold therapy does not help with those types of edema. They need other types of therapy and sometimes surgeries and other types of specialties to move the fluid out of the area. And we do those things too, just not now. Pain control, use it for 15 to 20 minutes or for pain control, and it can give you pain relief for 1 or more hours. You never want to use pain. You never want to use cold longer than 20 minutes. And we'll go through that in a second. Okay, so let's talk about MS for just a second. We've talked about a few diseases before, but you're starting to talk about them in pathology before. But specifically MS, they are very heat sensitive. That's where it says heat exacerbates multiple sclerosis. It makes their disease worse. It can make their day worse, or it can actually make their disease progress. Just being out in the summer for a few days can make their whole disease process progress. So we try to keep them out of the outdoors in the summer. We try to, if they've got to go somewhere, we try to get the person to turn their car on for them and let the air go for a while before they go and get in the car, so they have to sit in the hot car. But during therapy, a lot of times we will use cooling vests, and those are basically like vests and cargo pants that have big pockets in them, and you basically put ice packs in the pockets all over their body, and it cools them down really fast. Because if they come in and they're just worn out if they can get worn out and their strength can wear out going from their car to the front door of your clinic and getting onto the mat. That can wear them out right there. So give them the cooling the cooling vest with like cool packs. They'll get their muscle strength back pretty quickly, and then they can actually do their therapy while they're wearing the cooling vest, and they'll have more benefits of the strength than the therapy. We will go through that later. Cryokinetics is combining the use of cold and exercise in pathology and disease. Is commonly used in athletics, and what they usually do, the most common way to do it is to sit in an ice bath, a full body ice bath immersion for 20 minutes until you're numb, and then performing high intensity strengthening and stretching exercises for 3 to 5 minutes until your sensation returns. That's what cryokinetics is. It's cold movement. That's most often performed by athletes. You can do it up to 5 times before you've got to stop. Cryo stretch is the application of a cooling agent before stretching. I don't know how much I believe in this, because when I think of something cold touching me, I'm gonna like not loosen up and get relaxed. I'm gonna, if somebody with a cold hand or a cold object touches me real quick, I kind of like get tighter. I kind of jerk and like get more what's the word I'm looking for? Uptight. So I don't see how applying quick ice and then stretching would work. But let's see if I can see a picture of it. Oh, I don't.
Mr. Allen?
Yes.
I think we have growth and development at 10:30.
I know. Oh, and it's time. Okay, I have to stop. Okay, so what we'll do, y'all read this lecture on the rest of your own. I got through most of the important parts, but be ready to practice with hot packs and cold packs in lab, and be ready to test sensation and skin integrity too. There's videos on all of that. Okay. Okay, I'm sorry I kept all